Is much better.
All right, so with all the permissions, we're letting the delegates to join in.
Yes, please.
Shall we start, ma'am?
Yes, please.
May I have the attention, esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and distinguished faculty members of the session. So good evening and a warm welcome to all the dignitaries present here. I'm Ankita from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Planet serves as a digital partner for this event hosted by the Society of Onco Anesthesia and Perioperative Care. And the focus of today's session is anesthesia for prostate oncosurgery. Let's begin today's session, for which I would like to invite Dr. Anjali ma'am to take over. Over to you, ma'am. Kindly proceed with your talk.
Good evening, everybody. Thank you for joining us this evening. It's been a little lag time that we've had since we started delaying our webinars and spacing them out. So it's nice to be back together with you. This is our 45th session, and today we're going to discuss prostatic malignancy. We have, Ankita, can we have the introductory slide for Dr. Gauri? We have Dr. Gauri Gangakhedkar with us today. She is currently the assistant professor at TMC Mumbai, at ACTRAC Mumbai, and she has a fellowship in neuroanesthesia and has been awarded with the best paper presentation in various conferences. At this age, she has a lot of interest in academics and in research. As you can see, she's got multiple publications, has written book chapters, and has interest in onco-anesthesia, neuroanesthesia, especially, and patient safety. She's done a lot of work in publicizing our CPR program and is interested in the difficult airway as well. She's also an alumnus from Hinduja Hospital for her DNB. Hence, she is well versed with the brachytherapy for prostate. So she's speaking with us today. I would like to welcome Gauri. Gauri, please share your screen.
Is my screen visible?
Yeah.
Thank you so much for having me here, Anjali ma'am. It is really nice to be part of the SOPSI fellowship. I'm alumnus of Hinduja, and it's really nice to be able to hang out with her like this also. So today, ma'am has given me the opportunity to present anesthesia for prostatic malignancies. Why we need to understand prostatic malignancies is because it's currently one of the most frequently diagnosed cancer among men in 112 countries. It's also the leading cause of cancer death in 48 countries. Every year, apparently, 1.4 million, close to 1.4 million new cases will get diagnosed and 0.37 million people will die of prostatic malignancies. If you look at age distribution, you will see that most of these men, more than 99% of them, are more than 40 years of age, with the median age of diagnosis being 67 years old. The AIDS standardized incident rates for South Central Asia is 6.3 per 1 lakh population, which is possibly the lowest there is in the world, with the other races bearing the brunt of prostatic cancer. So why are we still talking about it? Is because in spite of this low incidence globally, 60% of the prostatic cancer burden from South Central Asia comes from India. So our incidence is 34,500 cases per year, with 16,000 of them dying. People who actually get diagnosed with prostate die. Hopefully, through the presentation, it should become clearer why this happens. We understand from the epidemiology that most of these prostatic malignancies are slow-growing, low-grade tumors, which are relatively low risk and have limited aggressiveness. However, if you look at the 5-year survival, you find that in Asian countries, the survival is 61.9%, whereas it is much, much higher in Europe and North America, respectively. Why is low 5-year survivals exist are possibly that initial early symptoms, and whatever symptoms occur, they are very similar to benign prostatic hyperplasia. So it's possible that these the geriatric population, there is some confusion with regard to the symptoms. There is lack of healthcare. They only present to the hospital when there are late symptoms, which are also fairly non-specific because there could be fatigue due to the anemia that sets in, or bone pain from the metastasis. When the paralysis, unfortunately, some of the symptoms would include paralysis from the spinal metastasis and renal failure from bilateral ureteral obstruction. So what are the risk factors for prostatic malignancies? They are older age. Like we saw, the median age of diagnosis itself is 67 years old. So the older you are, the more likely it is that you develop CA prostate. Additionally, there is ethnicity. African Americans and Hispanics are far more likely to develop CA prostate through their lives as compared to Caucasians and Asians. Having a first-degree relative with an early onset of disease leads to an increased risk of developing prostatic cancer. In fact, a 6 times higher likelihood of developing prostatic cancer. In addition to that, these patients are also more likely to have a recurrence after radical prostatectomy. Obesity is also a cause for increasing the risk factors. Now, how this obesity works is in combination with diet. So what they found is that while Asians are inherently at a lower risk of CA prostate, when they move to the West, the second generation remains at a greater risk than the first generation did when they migrated. So Western diets have been implicated in the risk factors for CA prostate. In addition to that, there is a sedentary lifestyle, persistently elevated testosterone levels, and chemical exposure to Agent Orange. So are there any preventive or protective measures that we could take to ensure that patients do not develop CA prostate? Apparently, a Mediterranean diet, which is full of high antioxidants, would help. Aspirin has been found to have some role in preventing CA prostate. So large number of these men who are more than 50 years of age who are receiving prophylactic aspirin for hypertension or ischemic heart disease apparently find some protection because of it. Since it is the anti-inflammatory mechanism which appears to provide protection, metformin, which inhibits the COX-2 and PGE2 axis, and also NSAIDs and statins have found to have some role in protecting the population from CA prostate. If you look at the etiopathogenesis, you find that the prostatic cells are highly susceptible to malignant transformation. The mutation in prostate glandular cells usually begins in the peripheral basal cells. Now, a carcinogenesis is linked to the embryonic organogenesis, which means that it relies on androgenic hormone signal, which the expression of the sonic hedgehog or the GLI1 oncogene. More than 95% of the diagnosed primary prostatic cancers are adenocarcinomas. These tumors are located mostly in the peripheral zone, which, to be honest, makes it slightly easier because they can then be palpated via digital rectal examination, and they provide a means to provide a clinical diagnosis. These tumors may remain localized within the prostate for decades, or when they do start growing, they grow very slowly. They do have a potential for metastasis, but this metastasis is slow, rare, and when it does occur, it occurs to bones and lymph nodes. It goes through the bones via the prostatic venous plexus, draining into the vertebral veins. So what's the clinical presentation of CA prostate? Like I discussed in the slide before, usually there are no early symptoms at all. Most of the cases in the West are diagnosed because they are screened for prostate-specific antigens as a part of protocol, which also possibly explains why they have early detections, and as a result, why they survive longer after diagnosing with CA prostate. They tend to have decreased urinary stream. They can have urgency, hesitancy, nocturia, and incomplete bladder emptying as symptoms, which can fairly well be confused with as non-specific symptoms or those with BPH, and can be ignored if a patient is not educated with regards to the fact that this could indeed be a symptom of CA prostate. So how is CA prostate diagnosed? This is with PSA screening, which is common in developed countries in high-risk populations. But PSA screening itself is fairly controversial. Why is it controversial? Is because there isn't really a magnitude. So X amount of magnitude increase of PSA doesn't tell you how invasive the malignancy is. And even more importantly, even a diagnosis with CA prostate does not guarantee that this tumor is going to progress. It could remain encapsulated in the prostatic tissue for the rest of the patient's life. So it could remain indolent for the rest of the patient's life. And this PSA screening could generate an undue panic in the already anxious population. Then there is MRI screening with the PIRAD scoring. So the PIRAD scoring is the prostatic cancer radiological scoring, which helps you determine whether the lesion that is seen could be a cancer. It could be a cancer. Then there are the transrectal ultrasound guided tissue biopsies. You could have the PCA3 urine testing, the prostatic health index scoring, 4K test or exome testing. Largely what is used is the first three, that is the PSA screening, followed by MRI, PIRAD scoring, and transrectal biopsies. So this is the usual sequence for diagnosis. A patient presents. This is, of course, when I'm saying when somebody finds it out at screening. For most of our patients, when they come to us with, if they come to us with advanced symptoms, the disease has progressed beyond the prostate or is enlarged enough to cause obstruction, which is why the patient has presented to the hospital. So if it is diagnosed as a part of screening, the patient presents with raised PSA levels, after which they are usually advised a digital rectal examination, which provides a clinical suspicion of a firm nodule in the periphery. Then they undergo a MRI with the PIRAD scoring being done, which gives you a reasonable score with regards to the risk for this being a malignancy. They undergo transrectal ultrasound biopsies, following which the core is subjected to the calculation of a Gleason score on histopathological basis to figure out if or whether or not this is likely to be a malignancy, and then a diagnosis is provided. The European Association of Urology provides this flowchart with regards to how exactly do you stratify a patient coming to you with all of these things. You know, you have the PSAs and then you have the Gleason score, and how do you put this together and figure out what the patient should receive? So I've made a slightly more simple chart here, which shows the risk stratification. So a patient is determined to be low risk if their PSA levels are low, their Gleason's index are slightly low, and the MRI shows a localized tumor. So when you look at this bit, the low to intermediate risk bit, this is when the EAU suggests that we go with a monotherapy, choose one of the available treatment modalities and proceed with it, and that's likely to cure the patient. When you look at this circle where the tumor still remains localized, this is where we come in, right? Where it is only when the tumor is localized that these patients are subjected to curative intent surgeries, and where these brachytherapies and radical prostatectomies can actually occur, and the role of the anesthesiologist comes in. In patients who are at high risk and with locally advanced or even metastatic disease, it is not that surgeries cannot happen. It is that the nature of the surgery differs, and it is that these surgeries take on more of a risk-reducing capacity, wherein they are a part of a multimodal approach to sort of reduce the disease burden and make the patient's life easier. So if you have a lower intermediate risk patient coming, for the treatment modalities available are watchful waiting, active surveillance, external beam radiotherapy, low dose or high dose brachytherapy, and radical prostatectomy. The brachytherapy and radical prostatectomy are those which require anesthesia. So what is this watchful waiting with active surveillance? So like we said before, since CA prostate grows so slowly, it is likely, and the patient is already, say, 67 according to the median age of diagnosis, it is possible that they will actually manage their entire life course without really succumbing to CA prostate. It is their comorbidities that usually need help. So we do make a small differentiation between watchful waiting and active surveillance. And that is, if the patient is asymptomatic with a clinically localized disease and the life expectancy itself is less than 10 years for comorbidities or due to their basic age, then we call it watchful waiting, where we just watch and we intervene with a palliative intent if at all necessary. Surveillance is different. surveillance is in an asymptomatic patient with a very small lesion with a low risk disease, where you know that the life expectancy is more than 10 years. In these patients, what you would be doing is you're going to subject them to repeated PSA screenings, to repeated transrectal ultrasounds, to keep a watch on the lesion, and to step in when required. Active surveillance is also possible in intermediate risk patients, but a selected number of them. Now, what we do have to understand is that given the gamut of treatment modalities available also, no active treatment modality has shown any superiority over any other treatment modality or even over deferred active treatment in terms of overall or prostate cancer specific survival. This we're talking about in low or intermediate risk disease. Why this is important for us as anesthesiologists to know is that when these patients come to us, usually when it is a patient with CA prostate who comes for surgery, it is this old gentleman who's really frail with multiple comorbidities. And with oncosurgeries, there is always this pressure that the disease burden will grow. This patient is going to become inoperable. This patient is going to get palliated because we do not operate upon them soon. That may not be true in these patients. These patients are going to possibly be good candidates for you to optimize them before surgery. You have to recognize that there is a possibility that the tumor may not grow very quickly after all, may not really require surgery. So managing the comorbidities is essential. The other thing is that if these patients are at indeed a very high risk of perioperative morbidity or mortality due to any radical prostate, particularly for radical prostatectomy, they can be advised lesser toxic therapies such as maybe radiation for these patients if that seems to be better, because we don't really have any evidence to suggest that surgery is your best choice. Let's move on to the therapeutic interventions that actually do require anesthesia. For these, the anesthetic concerns remain the same. This is for whatever procedure they need, there are these baseline anesthetic concerns. That this is an elderly patient who's likely to be frail. They have multiple comorbidities which may or may not be optimized. They require nutritional rehabilitation because unless they come via PSA screening, they've been sitting at home with the disease for quite a while. They may require anemia correction because one of the symptoms of CA prostate would include hematuria. They also require physiotherapy. If these patients are put to undergo radical prostatectomy, it is a surgery that is going to demand that the patient have better cardiorespiratory reserves so that the outcomes are better. It would also help if they were able to increase their functional capacity in the preoperative period. Pelvic floor exercises started in the preoperative period have been shown to reduce incontinence after prostatectomy. So initiating physiotherapy on the first visit does seem to show some promise. Now, how do you work up these patients who are coming to you either for brachytherapy or for radical prostatectomy? Some basal investigations will remain the same. You do want a complete blood count since they're prone for anemia. You want renal function tests done because as this prostate, the CA prostate grows in size, it's going to cause obstruction and cause obstructive uropathy. So it could have a detrimental effect on the renal function test. Look at the liver function test, look at the coagulation profile, even for brachytherapy, because you're going to be inserting needles into a very vascular organ. You do also need to do a comorbidity workup. So I mentioned it simply as a comorbidity workup because it will have to be tailored depending on what comorbidities the patient has and what end organs are affected. An electrocardiogram would be a good idea, and since these patients are geriatrics, 2D echo can be asked for depending upon the patient's actual comorbidities and their functional status. We move on to the brachytherapy bit now. What is brachytherapy? So one of the treatment modalities for these is this brachytherapy, which allows you to give lower doses compared to the EBRT. Here you could have high or low dose radiation. What brachytherapy actually means is that you implant this radiation source using a transrectal ultrasound very close to the tumor, which will obviously reduce the dose of the radiation and thus reduce the toxicity that the radiation is likely to have on other healthy tissues and then give rise to side effects. So for this, the patient would require to be in lithotomy position so that, as you can see in the picture, the truss probe can be inserted, and above that, you can have the applicators go in. After the applicators go in, it is a routine. It's usually a practice to have a check CT done to ensure that the applicators are in place before the radiation commences. Now, if you notice, I put in two pictures. One is the low dose rate radiation, the other is the high dose rate radiation. Usually, for patients, the high dose rate radiation is used, which essentially means that these applicators are put in, these are implant catheters, and then radioactive implants are inserted into the prostate. So after the insertion of these implants is complete, the patient is wheeled in and radiation is provided immediately. Once the radiation is complete, these implants are removed. In the low dose rate radiation, what happens is these radioactive beads, if you can see the picture on the left, are put in through a needle and these seeds are left in place. These seeds continue to emit the radiation over prolonged periods of time, and they usually dissolve over, say, 6 months, and the patient can then go home. What are our specific concerns with regard to brachytherapy? First and foremost, that this is a non-operating room anesthesia is something that you have to remember. That it is the radiation oncologists who are going to be surrounding you and staff that is usually not used to providing anesthesia. Patient requires to be immobile for a very long period of time. Like we discussed, this is this prolonged high lithotomy that they position that they will give. After the lithotomy position is given, they will do a transrectal ultrasound to delineate the lesion, then put in the applicators, then put in the implants. After that, this patient will be wheeled in the same position to receive radiation, and then the radiation will be administered, which all of this takes a very long period of time, close to say 3 to 4 hours. So for all of this period, in this uncomfortable position, you need a cooperative and pain-free patient. Additionally, you need availability of monitoring technique and personnel to monitor. Because when the patient is receiving radiation, if you can look to the picture on your right, you'll see that this gentleman is lying down inside and you're standing outside monitoring them using a slave monitor because you cannot be inside while the radiation is being administered. These pictures are courtesy Dr. Anjali Pingle. Thank you, ma'am, for the pictures. So how do you manage anesthesia for these patients? So ASA standard monitoring techniques have to be employed for all of these patients. The technique of choice would be central neuraxial blockade, either subarachnoid block or you could use maybe spinal epidural. The alternative, these blocks are very useful simply because they are going to provide the immobility that you require. Additionally, the lower half of the body for the patient is going to be numb, so they're possibly not going to feel, they're not going to get pain because of that awkward positioning with their legs being in high lithotomy continuously for such a long period of time. Additionally, it's going to provide analgesia for the period that the applicator actually stays inside, which makes our life fairly easy, and monitoring also becomes fairly easy. The All India Institute of Medical Sciences has 2 papers which they've come out with recently in the past few years, which talk about their experiences with brachytherapy, and they've used combined spinal epidural anesthesia in a fair number of patients, and they find that it's easier to use. Supposing the procedure gets prolonged, their spinal anesthesia can be supplemented with an epidural top-up, and they're able to provide the levels necessary and have a very comfortable patient going in for the radiotherapy. Now, alternatively, if a patient refuses central neuraxial blockade, or if the central neuraxial blockade is actually contraindicated, general anesthesia can be administered. There are certain studies that say that pudendal nerve blocks can be given, but pudendal nerve blocks are slightly dicey because they could wear off through the procedure and then your patient could become uncomfortable. There are those who argue that saddle blocks could be useful, but even with the saddle block, the saddle block will not take away the discomfort of lying in that position for so long. There are also certain papers which talk about giving local anesthesia for, say, prostate, but to be extremely honest, I'm not very certain how comfortable it would be for somebody to be putting in needles into your prostate and then, leaving it like that with your legs tied up. Mild sedation is preferable, at least during the initial phase, so that the patient becomes comfortable and then they could be allowed to sort of wake up. So all in all, while central neuroaxial blockade really does seem to be the technique of choice, the choice is yours between a subarachnoid block or using a combined spinal epidural set. If this is particularly for those centers that don't really do brachytherapy, which is most of us, to be honest. From I spoke with our radiation oncologists as well, and they said that the All India Institute of Medical Sciences in Delhi and Hinduja are possibly one of the two centers that are actually carrying this out. So if you're going to start this program new, like apparently we are going to, in that case, you might really want to consider having that additional epidural, because there will be a learning curve even from there and with regards to insertion of the brachytherapy applicators and the beads. After the CT scan after the radiation is done, these applicators are going to come out, and then the patient is going to be shifted. Now, if the patient is absolutely all right, like there aren't too many major comorbidities, does not really require ICU stay, these patients can even go home. But some of them will require even ICU stays or HDU stays. This is a call that needs to be taken in advance, because if you're planning, particularly from a hospital administration perspective, because you need to know in advance if you are going to require a bed for this patient. Once this happens, you need to ensure that the block has worn off before, if your patient is there for daycare, but the block is worn off before you say that this patient is okay to go home. The patient must void spontaneously and eat something before they go home. So the key points to remember for brachytherapy would obviously be that this is NORA. Please remember that this is NORA. These are that you're not going to have the sort of help for emergencies in these locations as you would in your operating rooms. The OT staff is not going to be trained as well as your OT staff is trained to assist you in your time of need. So raising alarms or and any inadvertent in any calls for help are going to have to be very loud and clear. Vigilant monitoring is obviously essential. So NORA is not just NORA from the perspective of the health available. It is also that simply you are by yourself. There is nobody really watching the patient apart from you who is there anesthetizing the patient. So vigilant monitoring is essential. And most importantly, when you're using subarachnoid block or a combined spinal epidural, we do not allow positioning until the level is fixed, because if you noticed, it was a very high lithotomy. So there's a small bolster that goes in under the patient's hip. It's not very high, but it is there. So you don't want the level ascending too high because you gave the position too early. We move on to radical prostatectomies now. So when and why is of radical prostatectomy? This is obviously a standard treatment, very effective in tumor control because the entire tumor is going to come out. This is effective for disease control in localized disease. The EAU suggests that even in advanced disease, when there is some amount of lymph node spread, the prostatectomy can be considered, provided you're able to achieve a clearance, and then you start additional modality of therapy as well. In advanced disease, surgery can be used as a part of multimodal approach. And the adverse effects that you would see after the surgery would be impaired sexual and urinary function. You have two sorts of approaches, either open or robot assisted. When you look at open radical prostatectomy, the consideration that what you must consider is that you could have either the surgical considerations are like this. There are either a radical retropubic approach or a radical perineal approach. This surgery, the open radical prostatectomy, is a fairly morbid surgery which has a lot of blood loss. And all prostatic surgical procedures are long by their own definition. Even in the hands of an expert surgeon, they are not these 2 hours go in, go out sort of procedures. Because of this, these patients need to be on DVT prophylaxis. Now, like I said before, it's a highly morbid procedure where we anticipate a lot of blood loss, but this blood loss is very difficult to quantify because the field is oozy, the bladder can open, you don't really know what is happening. This blood loss is also very difficult to control because the organ is very vascular. It could lead to hemodynamic instability. Now, because of the positioning of the patient, it is very possible that if the prostatic sinuses do open, a venous air embolism could also occur. Now, prolonged surgery with such a lot of loss in such an old, frail patients also predisposes the patient to hypothermia. When we look at the anesthesia management, you need to have informed written high-risk consent. You need to counsel the patients with regard to the need for a post-anesthesia care unit or an ICU stay overnight. The patients require ASA standard monitoring, including invasive blood pressure. You can take a call with regards to cardiac output monitoring, depending on the patient's comorbidities, if you require that. Antibiotic prophylaxis is a must. Patient must have 2 wide-bore IV lines for transfusing fluid. Cold-directed fluid therapy with balanced salt solutions is the IV fluid therapy of choice. You can use stroke volume variation or pulse pressure variation depending on what you have available to help you determine how much fluid you want to give. You prepare for a massive blood loss. You make sure adequate IV fluids are available in your OR. You cross-match adequate blood and blood products. You need to alert your blood bank that you're taking a patient who's likely to have such a massive blood loss, so that they're also prepared with their equipment and blood products. The patient fluid and blood must be warm. So the patient warmers, fluid warmers, and blood warming devices have to be available. Patients need to be padded in position. So what is this position that we're talking about? It's usually supine with a hyper extension between the pubis symphysis and umbilicus, so as to give them a little more space to operate. The legs are always in stirrups, either with or without low lithotomy position, and there is some amount of spindle involved. For anesthesia techniques, the standard technique would be an epidural anywhere between T11 to L1 and general anesthesia with endotracheal intubation. Combined spinal epidural has been used is used in certain centers, and to be honest, they put it in L2, L3 or L3, L4, the level of T6. So there are centers that are able to manage it, but I would think that, to be honest, I've done the last open radical prostatectomy I have done was when I was training for my DA, and there was a lot of blood loss. So since we are lucky here at Tata Memorial Hospital to actually have a robot and surgeons who are skilled in doing robotic surgeries, we move to that. But if you ask me now, with that sort of a loss and with that sort of morbidity that is there and that uncertainty with hemodynamics, I would personally prefer a general anesthesia with an endotracheal tube. So the airway is under control. I can take charge of the hemodynamics much more easily, because here with the spinal epidural, there is a local anesthetic has to give rise to some amount of vasodilatation in order for it to act, which could mean that it will confound me with regards to hypotension and lead to further hypotension. But I was pleasantly surprised to see the study from Munich, which compared combined spinal epidural anesthesia with combined general anesthesia and epidural anesthesia in 1,400 patients who underwent radical prostatectomies, all open. So almost similar numbers received GA and combined spinal epidural. What they found in their center was that the operating time, post-anesthesia care unit stay, and total hospital stay was significantly shorter in the group that had received epidural anesthesia with combined spinal epidural anesthesia. They also found that the intraoperative fluid need and the need for catecholamines was also lower in these patients. However, what must be remembered is that 65 patients who received combined spinal epidural anesthesia did require a secondary conversion to GA. So while this seems heartening and honestly promising that maybe we can do it, the pessimist in me is still looking at those 65 patients who were converted to GA and thinking that yes, there is a potential possibility that your regional anesthesia will have to be converted towards the end. So again, this is a call that must be taken by taking into account the infrastructure of your institute, the experience of the surgeon, the experience of the anesthetist, and then you must take a call with regards to modality for anesthesia. Post-anesthesia care for these patients would include monitoring in the PACU or the ICU. For pain relief, you would use multimodal anesthesia with regional. Now, if the epidural anesthesia is a given, I would suppose, but in patients who cannot get epidural anesthesia for some reason, TAP catheters or ESP blocks have also been successfully used. DVT prophylaxis is a must. So because this surgery was of a highly vascular organ, and then there is having a lot of blood loss, monitoring drain output is absolutely vital. You have to watch for pelvic hematomas that could occur. ILS is a very real possibility because they're operating in the pelvis and retracting all that bowel away. The exaggerated lithotomy could potentially, and that too for such a long period of time, could potentially lead to rhabdomyolysis and then an ARF. Compression of lumbar or pelvic muscles for a long period of time due to that awkward position could also lead to myalgia. If we move on to robot-assisted radical prostatectomy, this has been a revolutionary surgery for prostatic cancers and honestly a game changer. So centers that move to robotic prostatectomies rarely move back to open ones. There's a sharp reduction in the morbidity with the use of robotic techniques. It is with laparoscopy, I suppose, but not for this. Just as a technique, robots seem to be safer and cause less morbidity. This stark advantage that you can see with the sharp reduction in mobility is definitely offset by the cost of installing a robot and having a robot, and the steep learning curves that come with robotic surgeries, and the limited availability of both the technique of both the robots and the expertise in developing countries. So when I say steep learning curve, like even if we talk as a center, initially when we started robotic prostatectomies, they used to take around 2.5 times longer than what they do now. So, even given that, even with the numbers that we have and the robot that we have, the availability of training, if that is the sort of learning curve that we're looking at, that curve is going to be there everywhere. And with newer surgeons, that will be there furthermore. So what are our anesthesia concerns? If you can see in your picture, the head is all the way down because this requires a 30-degree Cleveland work. High pressure pneumoperitoneum because they don't want the bowel, they only want the prostate. This is a very narrow, tiny pelvis that they're trying to look into. The patient is completely strapped, absolutely inaccessible. The logistics are really, really bad because the anesthetist is far away from the head. And usually when you're far away from the head and you're uncomfortable in general because you don't really have control over much, this is a long duration surgery. But unfortunately, that doesn't change much for our anesthesia practice, fortunately or unfortunately. Our goals will remain the same. We want the patient to have normothermia, normotension, normocarbia, in spite of all of this happening, and in spite of the fact that this patient is possibly going to be sick with maybe diabetes, hypertension, and the works. So this is going to be a challenge. So what are the safety measures that you can sort of insist upon before when you do robotic surgeries? Now, if you see over there, the robot is right in front. The surgeon's assistants are there, and the surgeon is there inside the console, and the anesthesia machine is pushed away to one corner, like it always is in robotic surgeries. In addition, at least this OT seems to be well lit. In our robotic theaters, there is absolute darkness with one spotlight going on top of your anesthesia machine and the anesthesia machine lit up. So there is really nothing that you can see, and everything that you need to see, you need to look for it. So how do I ensure that my patient is safe through all of this? First, I'm going to do a very careful positioning for this patient. I'm going to pad and wrap all of their extremities. Now, because there's a 30-degree Trendelenburg, there is a chance that our patient will slip. Because we don't want our patient to slip, we're going to strap them in. You're going to strap their extremities, you're going to strap their chest. When they strap the chest, you need to ensure that there is adequate room for ventilation so that the patient can breathe. Then you have multiple number of tubes going across from your anesthesia machine, which is very far away, right towards the patient, which includes your endotracheal tubes, the monitor cables, the circuit, your IV line tubings, the transducers for your art lines and whatnot. So you need to ensure that you have proper extensions, like proper length extensions that allow access. You need to secure your IV access, your arterial line access, central venous access, if the need be, your cardiac output monitors, all of this before the docking is even complete. Once you're done, because you're not going to get an opportunity under all of those drapes and with the robot and the surgeons to actually go under the drapes and make too many manipulations with the hand strapped inside. Once you're done once you're done instituting the access, you also need to ensure that the access is fixed properly and that your connections are not going to come loose in the middle of the surgery and you're not going to have blood loss from the arterial line because it wasn't connected properly, or the IV fluid actually going onto the patient's drape instead of the patient, those sort of things. Now, these fixations need to be secured before the robot is docked, and after the robot is docked, also you need to recheck to ensure that there is no compression from anywhere. Like particularly for IV lines and IV connections, you need to ensure that the IV fluid is still going well after everything is done. And the last line, like I'm so sure I'm coming off as a pessimist, but we need to prepare for disaster, particularly in centers that are starting off. You need to have an undocking drill always, just in case something goes wrong, just in case you need to get the robot undocked. The entire team must be sure of what is the protocol to be followed if we need to undock the robot and access the patient as an emergency. What is the monitoring to be followed? You need to have all of your ASA monitors in place. You need invasive blood pressure monitors for goal-directed fluid therapy. You can consider cardiac output monitoring based on your patient's needs, just like we spoke in your open radical prostatectomy. Because your patient profile is not really changing, your monitoring is not going to change much. You can additionally use this in both of these surgeries to ensure a proper depth of anesthesia. So what are our concerns with this surgery? First and foremost, it is that steep Trendelenburg. Steep Trendelenburg with 30 degrees causes a right ventricular increase in right and left ventricular stroke work, increased in blood pressure, increased pulmonary capillary wedge pressures, increases the venous return, causes an increase in CVP, which will reduce the venous drainage and potential increase in ICP and intraophthalmic IOPs as well. This impairment in venous drainage is also going to lead to something that you can see physically, which is a facial and airway edema, which becomes very difficult to handle at the end of the surgery. We will come to what to do and how to do for that as well. Then there is the pneumoperitoneum. Now, these concerns are largely, if you look at it, similar to those concerns which you would have if you were doing a prostatic surgery or say colorectal surgery with laparoscopy. But here, everything is exaggerated and you are far away from the patient. So what happens with the pneumoperitoneum is, in addition to that 30-degree Trendelenburg, you have the pneumoperitoneum, which causes cephalad splinting of the diaphragm and reduces the functional residual capacity by about 50%. Now, this may lead to a decrease in saturation, which I would think that would, the logic, our trigger happy response would be to increase the P, recruit the patient, and then that would solve your problem. But this could also lead to too much of increasing of that P could lead to decreased cardiac output as well. Then you will have a reduction in mesenteric blood flow, or increase in mucosal pH could lead to potential gut ischemia if this goes on for a long period of time. There would be reduced renal and hepatic perfusion as well. So what are the ventilation strategies you could employ? So there are different schools of thought with regard to this. There's pressure controlled or volume guaranteed ventilation or pressure controlled ventilation, which certain people say prove to be a safer bet with regards to provision of tidal volume. But honestly, there is no real evidence for that. There is a review article for there is a recent review article in October 2023 in the British Journal of Anaesthesia that talks about different ventilation strategies that could be employed in gynecological and urological robotic surgeries. And they also could not find any evidence to suggest one ventilation mode was better than the other. What seems to work is that rather than simply increase, like I said, they use an appropriate amount of PEEP. So 7 centimeters seems to be okay. If you increase it further, the cardiac output will drop further. So what seems to work better is an intraoperative recruitment maneuver to aid increasing saturation as and when required. You can prolong the inspiratory phase, give a 2:1, and maybe that will provide better oxygenation and better carbon dioxide elimination. Make sure that the peak pressures are less than 35. So when you put it all together, what are your concerns is that your blood loss is absolutely unreliable. Since we do have an arterial line in place, serial blood gases will help. Point of care devices can also be used, but you don't really have access to the patient's extremities for pricking the patient, so blood gases work better. There's an unreliability of urine output. Because it is a robotic surgery with those robotic arms, organ injury is a very real possibility. There could be an injury to the cornea, so you have to ensure that the eyes are padded. Peripheral nerves, because of the tight strapping, are prone to injury, the common peroneal being the most common. So padding all of the extremities properly using gel pads, or if not, at least gamgee rolls seem to be the best way forward. Even more importantly, if your patient has neurodeficits in the preoperative period, all of them need to be documented carefully. The facial and airway edema that we spoke about before, which happens because of an impaired venous return, is a real issue. Because at the end of your 8, if you have like an 8 or 10-hour surgery, you'll have the face puffed up and swollen, and you may not be able to extubate the patient on table. You'll have that would be an issue as well. Muscle injury that could occur because of the tight strapping could lead to rhabdomyolysis. So before you consider extubating these patients at the end of surgery, you have to assess them for any facial edema, corneal edema, or subcutaneous emphysema because of port insertion. Look for facial or laryngeal edema, which could lead to respiratory distress. Consider doing a cuff leak test after a long surgery to sort of ensure that there is no laryngeal edema. Remember that these are difficult intubations, and intubations are always elective. So you need to decide whether you're going to be able to, whether it's going to be safe to extubate these patients on table. The patients could potentially also have chemosis, which is self-limiting. Now, if you notice, all of my considerations do not include the whole call the blood bank, make sure blood products are ready. It doesn't mean that you don't need to cross-match blood. It is that the blood loss after a robot-assisted radical prostatectomy is significantly lesser than what you would expect with an open surgery, which is the primary reason why these surgeries are so brilliant. Also, that these patients can be are quick to ambulate, like would be with other robotic surgeries. For the analgesia, for the postoperative analgesia for these patients, multimodal analgesia needs to be considered. NSAIDs need to be used with caution in any patients with prostatic malignancies because of the potential obstructive uropathy. PCA can be used. Usually, since it's only a robotic surgery with small incision, regional anesthesia, particularly epidurals may not really, particularly central neuraxial blockade may not really have a role. But in case a local port site infiltration should be adequate. So what is better after all of this? Is it brachy or is it surgery? So there is a paper in 2020 which compares 25 studies with 61,000 patients, and what it finds is that there are comparable risks of prostate cancer specific mortalities, whether you give brachytherapy or whether you let the patient undergo surgery, and the biochemical recurrence rate is also similar in both groups. However, brachytherapy is associated with a lower incidence of erectile dysfunction and urinary incontinence. Though nerve-sparing prostatic surgeries are also being carried out, but they are obviously more, they can use for a more selective population. So whether your patient is going to be able to undergo those or not is questionable. Other therapeutic avenues that are usually explored for patients with CA prostate, one of those is cryotherapy. Now, cryotherapy is a technique that's not used very commonly. It is used when the volume of prostate is too large. The patient is unable to either tolerate radiation or there's no response to radiation. And like with brachytherapy, this is painful because the needles are inserted into the prostate using truss, and then the cryotherapy is initiated. So during the cryo, it's very painful, but the needles are taken out almost immediately. So these patients, you could choose to use general anesthesia or subarachnoid block or combined spinal epidural. Even these are good patients for daycare surgeries, so even a general anesthetic can be considered because the probes are going to come out, the needles are going to come out at the end of the procedure. Concerns will be similar largely to brachytherapy, and androgen deprivation therapies are also used in combination with other therapies. Then there is the proton therapy. This is the new upcoming external beam radiation therapy that that people are talking about for CA prostate apparent shows a lot of promise. They say that the protons will deposit their dose much closer to the beam, right? Instead of spreading out in further direction and causing unwanted damage to normal tissues, what it will do is it will focus its energies only on the cancer cell or as close to the cancer cells as is possible. So this will reduce the amount of radiation therapy which is absorbed by a patient's healthy tissues. The disadvantage is that there is heterogeneous spread cellular damage across the photon profile also. Meaning it's not necessary that the photon will do the same amount of damage every single time to every single cell, which may be a problem. Additionally, the costs are prohibitive, so there is no real consensus on whether this should be a part of first-line therapy. As per the EAU guidelines, this is not a part of first-line therapy. This is only being used in trials, only in certain centers. But when it does start, what we will have to remember is that this is an MRI suite where MRI-guided imaging will be done. Then this EBRT will be provided to those specific locations, which means that as opposed to the other external beam radiation therapy which our patients receive, which is lasts for 5 to 6 minutes, will last for 20 to 30 minutes. So for patients who are either unable to lie down or who are intolerant or have claustrophobia, you're going to get called in to anesthetize them. Then the anesthesia concerns will become similar to providing anesthesia for an MRI. Thank you. This is all I have. I'm hoping that the topic is a little clearer.
Shall I stop the presentation from my end, ma'am?
Yes, please. You can do that.
Dr. Anjali, ma'am.
I'm so sorry, I did not unmute myself. So basically, the questions can be put in the Q&A box. Gauri, if you want to start your video as well. So our first question that we have here is what volumes are used in spinal for brachytherapy? So I take that question. Basically, what we see is the duration of the procedure is about 2 to 4 hours. So what we have is initially we give the spinal, get the patient position. And then there is a long gap for 40 minutes where they're actually doing the planning. The planning takes time because they want to protect the urethra from damage. And once that is done, then they start actually placing their needles. Once that is done, the patient, the pictures that Gauri showed, the OT complex and the treatment room are adjacent to each other. So you just wheel the table itself inside, and then you attach to the slave monitor. You've got the visualization of the patient on the CCTV, and you can monitor like that. So that takes another 30 to 40 minutes. So it depends. So all of this will take about 2 to 4 hours, depending upon how easy it is to map the prostate and place the needles. This period is covered if you give a good amount of, if you give 20 milligrams of heavy bupivacaine and opioid. So that does it. And at the end of it, when you want to lower the limbs, then the spinal has sort of worn off and you don't get a significant amount of hypotension in that position. So all of this needs to be looked at. That was an excellent presentation. Gauri has covered all the modalities that were available. There are some more questions. The next one is cardiac output monitors and lap surgery. Which monitor? Gauri, do you want to take that?
Sure, ma'am. Ma'am, actually, I'm unable to start my video. Apparently, the host has blocked it.
Yeah, good.
Yeah. So the thing is that with regards to cardiac output monitors, I think it would depend on local availability. You would have to take a call with regards to what is available in your institute and what you can work with for that. Whether if we use flow tracks, very routinely for these patients because we have flow tests and we are comfortable with those. But even hemospheres or HPI monitors would be useful of course.
Sohan, do you want to add anything? We will take the next
Sorry,
question.
I'm driving. I'm not able to check. There was a lot of traffic and all these things being thrown. So please carry on.
Okay. So we have the next question. Are brachytherapy patients scheduled for a spinal to be admitted, or can they be done in daycare?
So there's no reason, ma'am, why they cannot be done in daycare. Just because a patient is supposed to receive a spinal should not really mean that they have to get admitted a day prior. If these patients are scheduled through the day at such a point of time that you can ensure optimal recovery before the patient is discharged, that should be fine. Of course, that has to take into account that after removing the implants also the patients are stable and that they are able to void urine on their own, and then they can possibly go home, provided unlike a lot of the patients from TMH where you ask them where you're going to and they say I'm going to Bihar today in the evening. So those may not really be the best patients to say let's do this in daycare, but a patient who lives close by, who can approach the hospital in case an emergency does arise, daycare can definitely be considered.
Yeah, so I would just add to that basically all our patients that we do take for brachytherapy are daycare patients unless their comorbidities dictate that they should be observed for a longer period. Only in that case they are admitted. Or if they need to have HDU or ICU care, then that is planned in advance and all those arrangements are made before. The other point about the patients going to UP, that is well taken. Most patients will have somewhere where they're going to stay for 24 hours. So even those patients you can do as daycare. Our next question is, what is the role or your experience with prehabilitation as a part of ERA's protocols in robotic prostatectomy?
I would not claim that we are able to implement ERAs completely in all patients undergoing robotic radical prostatectomies. But the fact remains that given the indolent nature of the disease and how slow growing these tumors are, these patients form excellent candidates for prehabilitation. And if anything has to come out of it, it's going to be something that's good. Like, if I were postponing another surgery, deferring another surgery rather, because I wanted to prehabilitate the patient, I would always keep wondering if there is a risk of the malignancy advancing to a point where the patient becomes inoperable. That risk is largely reduced in CA prostate. There is also evidence to suggest that deferring treatment by a period of even 3 months is perfectly safe and is unlikely to change outcomes. Again, this is in low and intermediate risk patients, not for patients with high risk or patients with already malignancies which have metastasized.
Our next question is, do you practice CPR drill for or undocking drill in your institute?
So ma'am, we don't practice it with the residents. Unfortunately, our theatre staff is trained for undocking drills. So what we have done is we've trained a certain group of OT technicians and nursing staff who are the only ones who are available in the OT when procedures are being carried out, just because they know what the CPR bit our residents have to, the CPR bit we train our residents, but the undocking drill with our residents, no, we do not do that.
So basically not the residents, but I think the group that there has to be a group of people who consistently do these cases. So
consistently, yeah.
Yeah. So within 6 minutes, you should
so
be
the ones who are actually going to help with the docking and using, they know what to do.
Yeah. Do you normally give a trial run before you start your robotic prostatectomy?
Sorry, ma'am?
Do you do a trial run before you start the robotic?
I think I missed that. You do a trial run of the positioning, yes. For all robotic procedures, the final position, before the docking even happens, when the robot is sitting quietly in the corner, we will strap the patient, move the patient into the final position that is likely to happen to ensure that tubes are not getting kinked, tubes are not getting pulled out, there isn't unnecessary traction anywhere, patient is not slipping. So all of those issues that can be corrected at that point of time are corrected, and then the docking starts. So we do that sort of a trial.
Yeah, I think also it's important to keep the patient in that position for a little while so that you can see how the hemodynamics or the respiratory things change. So what you said was also right, that you need to be ready to open. It's never happened. I've not seen it yet. There's only been one case in gynae, which I've seen where the robotic had to be converted to open, not in the prostate. But you have to be ready for that. So blood grouping, cross matching, all those things are necessary. The next question is, what is your normal practice? How much fluid do you give in robotic?
So, ma'am, our practice is, because you have an outline in situ, we would give 2 ml per kg, 2 to 3 ml per kg body weight as maintenance. And then as mandated by the PPV, we will do that, because the blood loss is very difficult to estimate with
Do
the
you
sort of surgery.
routinely place arterial lines for your robotic prostate?
Yes, ma'am, we do. We do.
So the usual practice is we don't place them as a mandatory thing. So the usual practice would be to limit your fluids. So there are 2 reasons for that. One, as you already explained, the steep head low for a prolonged duration. You could have cerebral edema. And the other thing is, if your bladder is full, then the urine keeps leaking out while they're doing the urethral anastomosis. So you need to be a little careful about that. The next question is, have you ever seen any incidents of VAE?
No, ma'am. Fortunately, no. Very, very fortunately, no.
Yeah, it's quite rare. I have actually seen one where the surgeon was using a Verey's needle. So that is one place where you need to be careful. The good thing is that we are using CO2, so it's rapidly soluble, and we can get away with. See, the Verey's needle is used before the patient is placed in lithotomy position and all that. So while the pneumoperitoneum is being instituted. So those things, yes, there is a possibility that when the prostatic venous plexus is opened, then there could be a possibility of venous embolism, which you have already mentioned. What also happens during that time is that the intra-abdominal pressures are raised by the surgeons to reduce the bleedings. This increases the probability. Luckily, I have not seen such an occurrence. So that seems to be really it. Are there any other questions at all? Is there anything that Gauri you would like to add? Any points? Nothing.
No.
And
I think these are patients who, ma'am, but the fact is, I think with the understanding of the CA prostate, I think what I am going to take home from really studying for this lecture is that this is one surgery where I'm not going to get pressurized. I'm going to optimize the comorbidities before I take the patient on the table. And we have something called the HRJC, where we have highest joint counseling for patients with comorbidities, who are ASA3 and more, where we have a session where we sit with the surgeons and the patient and their relatives and explain the risks of the surgery. This is one point where I'm going to actually be able to say that even if you don't choose surgery, it doesn't mean that we are going to palliate you, or it doesn't mean the end of the road for you. So it's not going to be a very desolate sort of conversation where we are going to be able to offer alternative modalities that have similar sort of success rates for these patients.
Yeah, that is a very important point. These are slow growing malignancies. So there's no urgency per se. You can take your time to work up your patient. And if you feel that the patient is not suitable risk for either open, so what has happened is that most institutes who have a robo have moved over to the robotic prostatectomy. And it definitely, if you have cardiovascular risk factors or respiratory risk factors, it is still a better modality than the open radical prostatectomy, because that is that there's a significant amount of blood loss that is involved in that sort of surgery. So I would say that I completely agree with you. Brachytherapy has good results as well. And the patient can be offered brachytherapy if, even on table, if you feel that the patient is unable to tolerate that position, or if you have any problems even after induction, it is okay to back out and offer the other therapy to the patient. That seems to be it. Very well studied. Thank you so much. You did a very comprehensive job. And thank you to the audience for all their questions and for the interaction. Look forward to seeing you a week later, 15 days later. Good night. I'll hand over to Ankita.
Thank you so much, everyone. Thank you for the valuable insights you shared on the platform. So with all the due permissions, can we conclude the session over here? Thank you.
Thank you. Good night.